Hi, everyone. My name is Megan Pollier. I'm the Clinic Partnership Manager here at MAVEN Project. And thank you all for joining us today and our friends over at Cherokee Health System in Tennessee for hosting today's session, which is titled Assessing Common Motor Problems in Children by Dr. Lynne Kerr. Dr. Kerr is a pediatric neurologist at Salt Lake City, Utah. She is interested in child development and genetic syndromes that alter the typical trajectory. She has been a co-director at the Shriners Hospital Neuromuscular Clinic, where she has worked with patients and families with chronic conditions such as Duchenne muscular dystrophy and spinal muscular atrophy. So with that, we are very happy to have Dr. Kerr, and I'll hand it over to you.
Good morning. So I did this talk a couple of months ago, and we're going to talk about motor problems in children, but I've tried to make it a little bit more general about things that you might see in babies and children that are not completely just motor. I don't have any disclosures to make, and this is, as Megan talked about, it's 1 AMA Category 1 credit. So my objectives are to recognize abnormalities in the physical exam of infants and young children, to apply this knowledge to evaluate possible conditions, to apply this knowledge and demonstrate what to do if one of these conditions is suspected. And then just to go over motor problems to me in this talk are problems moving, either from weakness, low tone, spasticity, and they don't necessarily reflect difficulty with just the motor system of the body, although we will talk about some of the pure motor diseases and about some really exciting developments in treatment of those diseases. So in my experience, the children from newborn to 6 months are the ones that my fellow PCPs in my hospital, at least, feel the most uncomfortable about. They don't give you much in terms of interaction or on exam, and it's kind of difficult to know if they're normal. The first month of life is the most vulnerable period for child survival, with congenital defects being one of the leading causes of death. These defects can be environmental or genetic. Most are obvious, many need surgery soon, although some, like microcephaly, may be missed early on. And then I will stress this a couple of times, it is so important to look at weight, length, and head circumference on every baby that comes your way. So one possibility that a baby could have it not be doing well is metabolic disease. There are so many metabolic diseases, and we're kind of discovering more syndromes over time. They can present with variable timing over weeks to many months, even the first day of life, and variable symptoms, although weakness and hypotonia are very common. Lethargy, failure to thrive, poor feeding, hypoglycemia are also symptoms, and the onset may be acute and obvious or gradual. And again, weight, length, and head circumference to monitor growth. So one of the things we look at is failure to thrive. This is a horrible term. Families hate it. I was the mom of a child with a genetic syndrome, and after I complained about the use of the term failure to thrive, I ended up having to give a couple of talks to the nutritionists in our hospital. It kind of implies, I think, to families that they're not feeding the child well. So just be careful of that. There are many causes of failure to thrive that are way out of my area, like cystic fibrosis, celiac disease, kidney disease, genetic syndromes, muscle disease may present with failure to thrive, lethargy, and weakness. It could also be a symptom of neurologic disease if the child is not swallowing well, or increased energy needs such as heart problems, and then obvious environmental causes such as neglect. Motor problems are very non-specific. So let's start with an example highlighting how difficult it can be. So here we have a 2-year-old boy, he's not walking. So kind of where do you start? How long has he been walking? Has he never walked, or did he walk and then just stop yesterday? So is he developmentally delayed? Is there any relevant history? Did he have a fall? Does he use medication? Is there a family history, birth history? One example would be he would be 3 months premature. Does he have any associated symptoms that went with the not walking? Fever, pain, swelling in a knee, or even something as obvious as he was born without a foot on the right due to amniotic band syndrome, and he gets around with crutches. So you just really have to go back to the beginning. So there are many bugaboos about evaluating motor problems in children. And one of them is that kids don't come in and tell you that they feel weak. You have to observe them. So having them walk around their clinic, hopefully looking at them when they're going into the exam room. Then you also need to compare their abilities right when they come to see you to standard charts of what they should be doing at that age. And then there is a difference between tone and strength. That's kind of difficult, I think, to understand at first, with tone being the resting tension in the muscle, and strength is how much force the muscles can exert. Another problem is that families often come in with their babies asleep in their arms. You have to unbundle them and put them on the exam table to observe them. And then finally, you can't do strength testing on a young child. You need to just watch them, and sometimes you have to watch them for a few minutes. So let's talk about what's involved in movement. There's the nervous system, central, the spinal cords and peripheral nerves, the muscles, the skeleton for muscles to attach to, energy so that muscles can move, sensations so that the body knows where it is in space, genetic conditions, metabolic disease, and others can affect all or any of these. And then also think about brain damage preterm or at delivery. So starting with infants, evaluate movements of an awake newborn. So the baby on the left in the blue and white outfit has good tone. A newborn baby should be kind of all curled up in itself instead of lying splayed out like the baby on the right. You also have to look for symmetry over time, and you might have to observe them for a few minutes to see this. The tonic neck reflex, which I'll talk about in the next slide, makes this more difficult. And then are they moving their arms and legs with good strength? You may need to ask parents for a history of their movement. One thing that sometimes happens is that the parents see them when they're being changed. They don't want to be changed, so they're fighting a little bit, and the parents get to observe more movement than you might. So this is the tonic neck reflex, which can be seen up to 6 months in babies. And they look out at their fencing arm and they have their other arm up behind them. So obviously, if they're in this kind of a posture, they're going to look very asymmetric. But maybe you look back in 2 minutes and they're facing the other way. So that's okay. But another reason why you have to watch for a few minutes. Here's a baby with normal tone on the left, and then a floppy baby with hypotonia on the right. And the floppy baby, if you got the baby upset somehow, might be able to kick well, but just the resting tone is very low. And then here's another picture of the floppy baby in a C shape over the hand. And then even newborn babies should be able to try a little bit to keep their head on their body if you're pulling them up by their arms. And this baby on the left is not able to do that at all. So other things to think about, what they should be doing developmentally for age. And then are their weight, OFC, and length normal for age? Reflexes should be present and equal, and they're usually pretty easy to get in a sleeping or calmly awake baby. And I would make a case that you should have a good hammer. Amazon.com has inexpensive hammers. And my favorite is the Queen Square Neurologic Reflex Hammer. It's quite long, but it's plastic. It's very light, and it's about $20. I used mine for years and years and years, actually, until I think one of the kids in my practice took it by mistake. So I had to get another one. Let's talk about gross motor milestones. So newborn head lag moves arms and legs equally. By 3 to 4 months, they should have no head lag and they should be able to roll belly to back. At 5 months, rolling back to belly. At 6 to 8 months, sitting. At 9 to 11, crawling and cruising along furniture. Over the year of 1 to 2 years, walking, doing stairs, bending over and straightening up. By 2 to 3 years, they should be able to run and jump and walk on their tiptoes. By 3 to 4 years, they should be able to balance pretty well, ride a tricycle. And by 4 to 5 years of age, they should be really pretty good on stairs, alternating feet. Fine motor milestones are a little bit more difficult. They're not as many in the early days. So 0 to 3 months, the baby should have their hands fisted all the time. That's that good resting tone, bringing them to their mouth. By 3 to 6 months, they can bring their hands to midline, They can grab an object briefly, and they're starting to transfer to the other hand. By 6 to 9 months, the baby should be able to rake an object in front of them like that. They should start getting the pincer grasp, and they should be able to hold 2 objects in each hand. By 9 to 12 months, they should be pointing. They should be able to put small objects in a cup and turn the pages of a book, especially a book with thicker pages. By 12 to 18 months, building a tower, using a crayon on paper. And then not until 18 to 24 months should you note a hand preference. So a hand preference before this time is abnormal, and we'll be talking about a case with that, but should be investigated. And then finally, speech and language milestones. I won't go through all this. I just kind of put it there for completeness. But by 1 to 2 years, there should definitely be words. Then they start putting them together. So let's talk about this case. Case 1 is a 4-month-old baby brought in by his parents as he's floppy and not gaining weight well. The baby was born at home without prenatal care as the family doesn't have insurance. They tell you that the baby was growing well compared to the mom's other 3 pregnancies until the last couple of weeks. And some of you might be able to look at this baby and understand what this baby has. So when you start examining the baby's floppy, lying awake with arms and legs splayed. He's not moving much. He seems to have some weakness as well as low tone. And then the baby looks a little bit unusual to you and has a single transverse crease on the left palm. The right palm looks typical, and that's shown in this cartoon here. He's not particularly alert. So common causes of floppiness and weakness include various genetic syndromes, with Down syndrome and Prader-Willi being the 2 most common. And the child, as you likely recognized, has Down syndrome. So the incidence varies according to maternal age, but it's about 1 in 1,000 live births. They can also have metabolic problems, with hypothyroidism being the most common. Newborns are checked for this, but this baby was born at home. Most home births with nurse midwives work with the state health department for newborn screening, but not all. And then multiple brain and muscle abnormalities are also possible. So when I was a resident in the hospital, we used to refer to kids with genetic syndromes as FLKs, or funny looking kids. So awful that we used to do that, and hopefully you guys aren't in places where people do that anymore. I just want to put in a plug to not use comments like that, although you probably don't already. Here's a baby with Prader-Willi syndrome. You can see that the person giving him a bath has to be maximum help keeping that head up. And here's a baby with congenital hypothyroidism. So I have been to court twice as a neurologist, not the primary care doctor, because I had seen a baby with congenital, I'd seen 2 babies with congenital hypothyroidism that had been missed by the PCP. So I'm making a plea that you always check what the newborn screening exam states, even if the parents tell you that it was normal, because it's possible to miss something. Many of them will have jaundice and poor feeding, poor muscle tone, and constipation. So let's talk a little bit about newborn screening. Different states have different conditions screened for, although some are found in every state. For instance, there are 32 conditions screened for in Massachusetts. If an abnormality is identified on newborn screen, it doesn't necessarily mean that the baby has that abnormality, but additional screening is necessary. The state health department in Massachusetts, at least, contacts both the primary care and a specialty provider. They come up with a plan, then they contact the family with a plan, which usually includes repeat testing, and a referral to a genetic counselor is often a part of that plan. And again, always check that a child has had newborn screening and that you or somebody in your office has seen the results. So this is a list of conditions found by newborn screening in New York. There are very many. These are just the major categories. And I have nerve and muscle disorders in yellow, because spinal muscular atrophy and Duchenne muscular dystrophy have recently been added to the newborn screen. And that is because both of these conditions now have treatments, and it's important to find them early. Okay, case 2, we have a 3-month-old baby lying in a frog leg position with their legs very splayed out, but very alert and looking at you. The baby looks skinny. When you look at a weight chart, you note that the weight is only 10th percentile. Parents tell you that the baby has seemed different from their first child since day one, floppier and not moving much, but seems to be having more problems with movement. Parents also tell you that bottle feeding is taking longer and longer, and they've noticed some coughing with eating. Excuse me. Allergy season. So when you look at the baby on physical exam, he's just lying there. He has decreased muscle mass. He has poor weight gain for age, and his breathing is abdominal. He's not using his chest muscles much, and he's not breathing all that well. It's not very deep. And this baby has spinal muscular atrophy. This is a genetic disease that affects the anterior horn cells in the spinal cord leading to muscle. And when the anterior horn cells die, then the muscles die off. There are 3 forms, infant, type 2, and type 3. We'll be concentrating on type 1 infant in this lecture, although you might see other types as well. So without extraordinary interventions, such as a home ventilator or a nursing home, these kids die before 1 year of age. This is an autosomal recessive condition. It's 1 in every 6,000 people born, but 1 in 40 people are carriers. So there are a lot of carriers out there. And SMA is the most common genetic killer in the first year of life. So this is just a cartoon of the nerves dying off between the spinal cord and the muscle, and then the muscle atrophies. So there's a normal process of cell death over the first few weeks of life in the spinal cord to the muscles called apoptosis that allows fine-tuning and coordination of movements as the baby develops. But in SMA, many of those anterior horn cells die off with a resulting increasing weakness because they are lacking a protein. So in SMA, intelligence is not affected, and these babies often are just very alert and looking at you. It's caused by the deficiency of the spinal motor neuron protein SMN that's necessary for normal motor neuron function. And its deficiency is caused by genetic flaws or mutations on chromosome 5 in a gene called SMN1. To make matters more complicated and to explain why it took us so long to understand this condition, there are also spinal motor neuron 2 genes that can in part compensate for the lack of SMN1 genes. Babies with the most severe type of SMA, type 1, have little or no SMN2 protein. Kids with the less serious SMA have more SMN2 protein. So I am delighted that during the course of my career, genetic treatment for SMA has become available. We used to just watch these babies die over the first year of life or over the first couple of years of life in the other cases. The name of the medicine is Zolgensma. It's given only 1 time. There are others too, that some are given more than once. They're all put into the cell by a adenovirus vector, which complicates things because it can make some babies sick. But babies who would have died at age 1 are alive years later. We don't have long-term data yet because this has only been out for about 5 years. And these children are not normal for age, but they can often walk with some things like walkers, and they're not on ventilators, and they're alive. And because of the changes that these medications have made in lives, we don't really use SMN1, 2, or 3 anymore. We use sitters, non-sitters, or walkers. Especially for this disease, more than any other, the earlier a child gets treated before a lot of the motor neurons die off, which happens in the first few weeks of life, the better they do. 1 week is much better than 3 weeks. So insurance pre-authorization causes a problem, and we spend a lot of time trying to get the insurance people on the phone and get it approved. So just to give you an idea, Zolgensma, the last time I looked, was $2.3 million, but you do only need to give it once. There are programs for children that are non-insured, as long as they are citizens, although I did manage to get it for 1 baby that was here illegally from Mexico. So it is possible, but a lot harder. And insurance companies, once they are confronted with the story, will usually pay if the child has insurance. Medicaid is paying for this in our state, at least. Because kids get bad over just a few weeks, diagnosis and treatment here is an emergency. The earlier the treatment, the better the outcome. Genetic testing is easily available. It can be done by mouth swab, and the cost is in the hundreds of dollars, not the thousands of dollars. I would suggest, especially if you're in a rural area, to refer the child by phone to a neuromuscular center. Many are all over the country, and the website curesma.org is also helpful. Again, genetic treatment is available and is life-saving, and they will help you get a child in very quickly. You may also find out that a baby in your practice has its diagnosis by a positive newborn screening test. It's really an amazing story. Family and parent advocacy groups have been successful in getting this and other conditions added to newborn screening, and it wasn't available on newborn screening even 5 years ago. And diagnosis by newborn screening will enable the treatment to be available sooner after birth without waiting for the baby to become symptomatic. And hopefully within the next couple of years, this will be available in all states. So another case, same age child, but this time we have a 3-month-old baby lying in a frog leg position, interested in you with little movement, but this one seems sleepy. And the parents tell you that the baby was completely normal a week ago. And you kind of think to yourself, how could this baby have been normal? You cannot get any reflexes. You're pretty sure you're doing it right, but there's just nothing there. Very few movements. And then the parents tell you that the first thing they noticed was severe constipation. And then he didn't seem to want to keep his eyes open. Then they thought his cry was weak. And then they noticed he was not swallowing well. You examine the baby and see that he's having trouble breathing with fast, shallow breaths. And this baby actually has infantile botulism. We see a couple of cases in my hospital a year. It's spread by honey and dirt spores, but now that we tell mothers and fathers not to give honey to their newborns, dirt spores are much more common. So we often see this in farm areas where it's quite dusty, or in new developments where there are a lot of houses being built. The spores produce toxins in the colon, which block the junctions between the nerve and the muscle. The peak incidence that we see this at is at 13 weeks of age. The constipation is really amazingly extreme. Then they have cranial nerve, and then they have body weakness. The airway needs to be protected because their swallowing is bad, and they often need a ventilator. So most of these kids will recover. It might take months, but if you make the diagnosis and an antitoxin is given, it might only be weeks. You can diagnose it by EMG or a stool sample, although with constipation, it is very difficult to get a stool sample. Often just the clinical picture will lead to treatment. Case 3 is a little bit older, a 1-year-old girl whose parents state that she isn't moving her right side as well as her left. She's been left-handed as long as they can remember, but they say like Uncle Joe is left-handed, so they didn't worry about that. She also has strabismus, which you can see in the picture there. And they brought this up to their pediatrician, who said he just wanted to watch her. When you examine the child, you think the right leg looks a little smaller than the left, and that the reflex on the right side is increased compared to the left. So again, you're looking for that symmetry of reflexes. She uses her left hand almost exclusively, but she's really good with using that. And she's interactive and makes a lot of noises, and you feel that she is either developmentally appropriate or near appropriate. So this little girl has hemiplegic cerebral palsy, with cerebral palsy being the most common cause of childhood injury. All it means is non-progressive injury to the brain occurring at, before, or soon after birth, limiting mobility. It only means limited mobility. It can be associated with intellectual disability, eye problems, epilepsy, but these are not part of the diagnosis. There are many causes of CP. Genetic conditions, tumors, prenatal stroke, intraventricular hemorrhage. The workup is important here, although not emergent, but you need to find the etiology and ensure that there's no further treatment needed for the underlying condition. For instance, if there was a brain tumor. Treatment is needed for the CP and associated conditions, such as PT and OT for spasticity, speech therapy for speech delay that may be present. And we have many things that we can do for the spasticity, such as injections of Botox, surgery. And this is an MRI from this child. You can see that the ventricle on the right is much bigger than the ventricle on the left. And if you look at the sagittal section through the brain, that little white area is the corpus callosum, and it is very thin compared to the normal one. You also think that maybe the gyri of the brain look a little bit atrophic there. I am always amazed at how often medical people, including myself, I've done it too, can miss hemiplegia until the child gets older. It's often not noticed until the child starts preferring one hand much earlier than they should, with the normal being almost 2 years of age. And hemiplegia is the most likely type of CP to have no intellectual disability associated with it. So these kids can intellectually be pretty normal. Here is a 5-year-old boy with hemiplegia. You can see that his left hand looks soft and he's ready to use it, but his right hand is contracted and very tight. You can also see that he looks really alert and ready to go, and fun kid to be around. So what can you do for a child with cerebral palsy? Most of the causes don't have anything that you can really do, but there are early intervention programs providing services for children under the age of 3 with developmental delays and disabilities. These include a full range of services to meet individual needs and the needs of the family, including PT, OT, speech, and development. The goal is to minimize the effects of the delay. This is available in every state, in rural areas too. It's funded by the federal government, but the states each have the ability to run their own programs, and they run the programs differently. For some states, the program is free. For others, they charge. Medicaid will pay some money into it. It's different in every state, but present. I'm not sure what's going to happen to this program. I haven't heard anything to this point. To access this program, although you all might know this very well, you Google early intervention programs in the name of your state. They're also very useful to do evaluations and then follow children if you have concerns about a child's development, even without cerebral palsy, for instance, a child just with language delay. In many states, parents can self-refer if they're worried about their child's development and check the rules in your state. Okay, now we're going to change our direction a little bit. Now we're talking about a 3-year-old boy who walked a little late, mildly delayed speech, and not like running like his other kids in preschool. And that's why the parents brought them, because the preschool teacher brought that up. When you look at him, he has these large calves, and the parents actually say, wow, look how strong he is. Look at those legs, look at those calves. When you examine him, you note that he has tight heel cords. You can't get his foot up. And you notice that even when he's just walking, he has a pretty pronounced waddle. He can't run at all. And he has a positive Gowers maneuver, which is shown here. So to check a Gowers maneuver, I have boys, because Duchenne muscular dystrophy cases are always boys, have them lie on their back, roll over, and then show me how they get up. And most 3, 4, 5-year-olds kind of pop up from the ground. This kid has trouble rolling over. And then when he gets over, he has to have extensive views of his arms and shoulders, and then prop himself up on his knees to stand upright. So that is said to be a positive Gowers maneuver. And usually they're very happy to do this. So I guess I let the cat out of the bag in the last slide, but this boy has Duchenne muscular dystrophy, 1 in 4,000 male births, pretty common. Features are the large calves, difficulty running and walking, and the Gower sign. Unfortunately, most of these kids aren't diagnosed until after 5. It really should be happening a lot earlier. To diagnose them, you have to think about the illness. You can get a CK level, which is available in any lab, and the normal is around 200 to 300. These kids come back with a CK of about 20,000, showing that they're leaking muscle protein, or genetic testing by a mouse swab. The cost of the mouth swab to the family is approximately $300 and does not require any expertise. And like SMA, there are many places that are willing to help you with this diagnosis and treatment. So Duchenne muscular dystrophy is a progressive disease with increasing muscle weakness. Then it affects the heart. Because the muscles get weak, then we get scoliosis and death in the 20s due to pneumonia and cardiac problems. When I first started out as a neurology resident, these kids used to die around 14 or 15, so we're doing a lot better with good preventive care. Duchenne may be X-linked, so moms may have some mild features, some mild weakness, but it can also be completely de novo, out of the blue in a family, so the mom doesn't have to have any symptoms to make the diagnosis. This disease is due to mutations in the gene coding for dystrophin, a muscle protein. What we do know that works is steroid treatment, and then surveillance for known problems that may occur helps greatly. So these kids need really good preventive care. New treatments are becoming available, and they should be followed in a specialized clinic. So we used to have to get biopsies a lot more before we had genetic testing, but I just wanted to show you what a biopsy looks like for what this does to muscles. So this is a normal muscle biopsy. You can see that each muscle cell or fiber really looks pretty regular. The nerves and blood vessels are on the outside of the muscle fibers. It's very regular. In Duchenne muscular dystrophy, this all becomes completely chaotic. You can still see some muscle fibers, but there are very small ones and very large ones. The white areas are the fat that have infiltrated the muscles, and that's why this boy looked like he had such large calves, is there's all this fat in the muscle. There's more connective tissue. And then an early clue to the inflammation that is present in this disease is all these blood cells that are present. And those are inflammatory cells. And then quickly, this is just the dystrophin gene, the normal one in the light blue and the abnormal one in the dark blue. The Duchenne gene is bigger than almost any gene known to man, and it has 79 exon areas. And in this particular child, he is missing 3 exons, giving him Duchenne dystrophy. This is also the same gene that causes Becker muscular dystrophy, which doesn't even show up until around 10 or later, and those people can live into their 50s, and those are just different gene mutations, but it's really the spectrum of the same disease. So until recently, prednisolone was the only treatment we have. So it keeps kids alive longer for the 20s versus the teens, keeps them walking longer and out of wheelchairs, teens versus about 8 years of age. It reduces their scoliosis, their heart problems, and their lung problems. Steroids have many side effects, though, including obesity and osteoporosis, but mostly behavior problems. And many parents say, I want my kid back. I just can't stand the behavior on the prednisone. Some of these children have autistic features, attention deficit, and learning problems, and they become just kind of impossible to live with on the steroids. So the family stopped giving it to their children. There is a new steroid that has come out just recently, vamorolone or Agamree, and givinostat, which is not steroid. It's a different medicine. And they may work better by preventing problems with muscle function, by decreasing inflammation. But frankly, they haven't really been out all that long. They look good in the clinic, but it's really not sure how much this is going to change the landscape. There's also genetic treatments available. They're not cures, just treatments. Several available. Elevidys is general. Others vary with the mutation. These are available at neuromuscular centers, and there are definitely programs for boys without insurance, and Medicaid will pay for these medications, at least in many states. So dedicated neuromuscular centers all over the country. We have ones from the Parent Project Muscular Dystrophy, the MDA, or Jerry's Kids, if any of you are old enough to remember that. And a child with suspected DMD should be seen within a few weeks. If the Parent Project Muscular Dystrophy or MDA clinic is contacted. They'll help with the referral and get that kid in. They'll also help with financial arrangements for non-insured children, and they don't care at all whether a child is here legally or not. And I just put some contact information here. You might also find out about this diagnosis from newborn screening if you're in a state lucky to have that, and the state health department will help you figure out where to go next. And this is a map of the care centers that are available just from the Muscular Dystrophy Association. There are many, including one in Puerto Rico and one in Cuba. It's very easy to find help. Okay, moving on. Next patient is a 6-year-old girl. You look at her, she has a very long face. She's mildly intellectually disabled and answers your question more like she's 3. She's drooling a little bit and has ptosis. And you look at her mom, and she really looks a lot like her mom. When you examine her physically, you see that she's weak distally greater than proximally, like she can't grip a pencil well. You put a pencil in her hand, and you can just take it right out. She has a long, weak face, and she has myotonia. And myotonia is the inability to stop a movement once initiated. So you can see it particularly well in the hands. You tell them to squeeze their hands tight and then open them. And like I can go like this, but those kids go like that. Also, when they close their eyes, they can't open their eyes easily. If you tap on their tongue with a tongue depressor and then a hammer, their tongue goes into spasms, and that you can also do that on the thenar eminence of the hand. And you might think to check mom for all these things too, as this mom looks like this kid and might also have myotonic dystrophy. The CK for myotonic dystrophy is normal. Myotonic dystrophy is the most common muscular dystrophy worldwide. We see it in 1 in 2,300 people. Children and adolescents in special ed classes that haven't been diagnosed come in once or twice a year. Again, it causes weakness, the prolonged muscle contractions, and myotonia. So myotonic dystrophy is not just a muscle disease, it actually affects the whole body. And people with myotonic dystrophy have early balding, cataracts, cardiac conduction effects, early diabetes, weakness, tiredness, contractures with club feet at birth, and other orthopedic problems. Some of these kids and moms have to take all these naps, and at first it seems like the mom has to be making it up when she tells you that she does the dishes and then she has to lie down and take a nap, but it is real. Also, the conduction defects can lead to frequent sudden death, which a pacemaker can prevent. So very important to have these kids followed by cardiology, and then have an EKG. And I had several patients that, I don't know, one young woman, probably 22, went out dancing with some friends, had an arrest on the dance floor, and died. So really important. So myotonic dystrophy, like many of these others, comes in a spectrum from congenital myotonic dystrophy, which just means you can see it at or near birth, to very mild signs and symptoms. More severe cases are more likely to be diagnosed early in life. The type diagnosed in childhood is called congenital myotonic dystrophy, but the nomenclature there is really kind of difficult. And this is a picture of 2 young ladies with myotonic dystrophy. So notice that their mouths are not closing well, their eyes are drooping, and they have long faces. And the picture on top is a young woman showing you hand myotonia. She can't relax those muscles. And the tongue on the bottom shows the tongue spasms that occur because of myotonia after I put a tongue blade on the tongue and then tapped it very lightly with my hammer. So I know that you guys, hardly anyone gets EMGs anymore. It's a dying art, but I wanted to show you what myotonia looked like on an EMG. So the bottom panel shows what a normal muscle would do if it's tapped. And you get 10, 15 discharges, electrical discharges of the muscle. But the one on top shows you what happens with myotonia. There are many, many muscle discharges, and it goes on for a long time. And indeed, if you were able to hear this, it would sound like a dive bomber. Myotonic dystrophy is an autosomal dominant condition. So if one parent has the condition, the child will have it too. Sex of the child does not matter. The child has a 50-50 chance of getting it with the parent. There is something, though, called imprinting, whereas if a child gets it from mom, the severity will be much worse. And so you might be called to the ICU to see a baby who is very severely affected, and nobody has realized mom even has the condition. So that is why it's important sometimes to do some of the myotonic tests on mom as well. So babies with myotonic dystrophy may be born weak with decreased ability to breathe. So think about this condition in a newborn with difficulty breathing. Check for myotonia in the moms. Decreased movements in utero may cause an asymmetric face, quite abnormal club feet and hip dislocations. And as children, they often will have difficulty speaking. You could see how they weren't holding their mouth shut well, difficulty swallowing, and usually a pretty mild intellectual disability, but usually they will need special ed classes. And 2 more pictures of some older kids with myotonic dystrophy. So in summary, although these are all uncommon conditions by themselves, together they add up. And you guys are seeing people all the time that are very young, and you have to keep on looking for multiple causes. Hopefully I've given you a little bit of a framework about kind of how to think about things. And I'd like to note that you guys are the first line of defense to find these conditions early. For some of these, especially spinal muscular atrophy and Duchenne muscular dystrophy, there are now treatments, and kids should get into specialty clinics, acknowledging that that is hard. They will help you. There is funding available for non-insured people. Some of these are treatable, Duchenne and SMA is an emergency. You only actually have a little bit of time, a week or 2 before there's too much death. In fact, there are some learning hospitals where they're trying to do injections of the genetic treatment even before the baby is born. So red flags, looking for good height and weight and OFC, making sure that that baby is doing well for that. Developmental appropriateness is really important. Tone, symmetry of movement and strength, and then of course, any decreases in ability and strength that the parents have noticed. I put the different areas for referral, newborn screening conditions, the MDA, PPMD, and Cure SMA, and early intervention programs. And some more. And questions?
Great, thank you, Dr. Kerr. That was a great presentation. Let's see if we have any questions. And just a reminder, everyone, please, you can use the Q&A box if you have any questions, or again, a reminder, if you want to directly speak with Dr. Kerr, you can raise your hand and I will happily unmute you so that you can ask your question. It looks like we have one question so far. The first question is, many of the spectrum kids present early in infancy with hypotonia. How do you work them up?
Autism spectrum, I'm assuming?
I would assume so.
So these days, so many causes of autism, especially ones that are showing up on showing up with low tone early after birth, will have a genetic syndrome that we can find. I usually do genetic testing for kids that are severely hypotonic. I mean, it kind of obviously depends on how bad they are, but I would look with genetic testing. So it's really easy to get genetic testing these days. We keep kits in our clinic. We just swab the kid. One of the MAs will swab the kid and it goes off. Insurance will likely pay, Medicaid will likely pay, or the company will often do it for free.
Cool. I don't see any other questions. Someone wrote a note, truly a fabulous talk. Thank you. Any last minute questions are welcome in the box, or again, you can request unmute. And just a reminder, you will get the CME survey once you close out of today's webinar. You will have to fill out that survey to get your CE credit, your CMA certificate, excuse me. And a reminder, today's date, June 5th, with Dr. Lynne Kerr. But if there are no more questions, oh, I think I see one come through. Let's see, it says, ever since back to sleep, many infants have motor delay unless we can get them to do tummy time.
I agree. That has become more of a problem. On the other hand, we really have decreased the sudden infant death syndrome numbers by a lot with tummy time. So I'm glad that we're doing that. But so just the motor delay, when you know the family's doing tummy time, their fine motor is okay, their speech is okay, I would kind of follow along with that. But again, you can use the early intervention program to do a developmental assessment. Almost always that initial evaluation is completely free. They don't care whether somebody has papers or not. And then if they're concerned, they can keep on watching it, which takes some of the onus off you to keep on following that baby really closely if you know that they're helping you.
Great. One last question. This is more of a general, well, they said, thank you for the presentation. What is your availability to discuss specific cases outside of the scope of this discussion?
So you can always put my name down when you do the MAVEN Ask a Question. I think you're allowed to ask by name. Is that true?
Yes, yeah, I was gonna say you can do mentoring requests and specifically requests, or if you are looking, if your clinic would like to do a big group discussion, similar to a webinar, but more informal, we can do mics off, cameras off. That is what we call a case-based learning session. It's much more informal than this. Like I mentioned, you'll be able to interact, directly speak with Dr. Kerr the entire time over specific specialty or discussion that you'd like covered, or case specific if you'd like. So if either of those are interesting to you, email us at our educations department or send in a request and we'll connect with you.
Yeah, happy to help. And I agree, if the newborn was born outside the United States, it's very important to follow up on the newborn screening. And it depends where. That's a great point.
Awesome. Any last minute questions are welcome. Put in the box, but otherwise we're going to be very happy to give everyone back 10 minutes into their day. I'm sure everyone could use it. So as always, thank you for joining us for today's talk hosted by Cherokee Health System. Today's talk is recorded again, so you can listen back on our MAVEN Project website. Within 10 to 12 days, it will be posted there. So thank you everyone and have a great rest of your day.